So I'm going to stop now, having set the issues of why you probably should have someone who knows what they're talking about, talking to the patient before they have this test. Otherwise, I think you could run into quite a lot of difficulty. So I'm handing over to Katrina, who's our excellent genetic counsellor, to discuss this.
Brilliant. Thank you, Tessa. Yeah, as Tessa said, this part of the presentation really is going to be focusing on kind of drawing together everything we've discussed really, both in this presentation and in previous presentations, in, how we run our service at 90 Sloane Street. And hopefully, you'll see the kind of importance of genetic counselling, genetic or genomic counselling in preparing patients for all the various potential outcomes of these tests that we offer. So really, I wanted to start just talking a little bit about the genomic counselling profession. And you see many different definitions out there, but I felt this one was concise and an accurate one that I liked in terms of the job role that I do here. And it's the process of helping people understand and adapt to the genetic, medical, psychological and familial implications of the genetic contributions to disease. And I suppose that's where my role differs from that of the geneticists. Whereas they have the medical background and can kind of do the physical examinations and know far more about the medical natural history of these diseases. My role really comes in the how patients adapt to the results, how they prepare for it, and just to really check that they have all the information they need to make the decision that's right for them in relation to genetic testing. So I work directly with patients and families, allowing them to make health decisions. And historically, genetic or genomic counsellors came from backgrounds in things like nursing and trained to sort of specialise in genetics, whereas now more and more we're training on master's programmes around the UK, and also as part of the NHS scientist training programme to specialise and be practising clinical scientists in different genetic centres across the UK. So what do I do? So the first part really of my role is assessing information. So at 90 Sloane Street, I'm the first point of call really for any queries we get from patients or any referrals we receive from GPs or specialists, and as well as the personal and family medical history. In that session I really focus on physical health but also mental health to see is there anything there that might impact a person's ability to cope with a result or adjust before they consent to go ahead with the test. And also how they perceive risk and their motivations for testing. It's very important that I set that agenda with patients to ensure that what we're offering them is going to address the worries and concerns that they have and isn't going to leave them with more questions than answers. Also to educate, so that side of my role, so population risks, risks in the family, inheritance patterns, and management and screening options. So how can we action the results of the tests that we're offering these patients? And discussion with patients is so important, and that really comes in helping them understand their result, but also helping them understand implications to the wider family. And in my role as a genetic counsellor, language is so important, and really listening to patients and how they talk about conditions. So some people we have, may undertake things like our preventive panel or whole genome screening. There may not be an existing condition in the family. But for some people that come forward, there is. So I saw a couple recently for testing, and she was a known carrier of a recessive condition, like Tessa's just spoken about. And she was actually pregnant, and her and a partner came forward because she wanted him tested to see if he was also a carrier, to see if the pregnancy was at risk of this recessive genetic condition. But the way she spoke about this condition, I asked very open questions, and she had a brother affected with the condition. And she spoke so positively about him and the joy he brought the family and their care of him. So it's so important to listen and frame my language and how I speak about the condition relative to how the patient talks about it. Because you don't want to use negative terms to refer to a condition if that's not the way it's perceived by a patient, whilst also making sure to give them the facts so that they understand restrictions of the condition, impacts of the condition, if they decide to have a test. And in this case, they didn't want to act on the pregnancy. They just wanted to prepare so that, when they had the baby, they were able to, know what the risks would be of the baby having inherited the genetic condition. Also alternatives to testing. So genetic testing isn't right for everybody. And again, that's a huge part of my role, is understanding, do these patients really want the result of this test that is lifelong? We can't take it back. Or actually might there be better alternatives? So for example, screening for a condition that might be present in the family without actually having a genetic test. So, I go in very non-directively and, from an unbiased perspective to make sure that they're making the right decision for them. So my role at 90 Sloane Street really, first point of call, as I mentioned before, and that's through emails or phone inquiries or official referrals that we get from consultants and GPs. So I'm full-time here, so I really gather that initial information from patients, understand their wants from the test, direct patient to any additional information we require before I see them in an appointment, or before I liaise with a consultant to discuss their case. And as part of that as well, I review family history information, and that is so important. And I think previously in our cancer and cardiac genetics talks, the consultants have emphasised the importance of family history. We could find a harmful gene change, but we might review what our recommendations might be for an individual based on the family history. And the first is really transparency of my role. So, would that person qualify for testing on the NHS, for example? And it's important people are aware of that if that is the case, or it might be the case for some relatives in their family if we consider them to be at high enough risk. I also meet weekly with a consultant, so there's an on-call consultant every week, and that allows me to raise urgent queries very quickly with them and address anything outstanding very quickly. And twice a week we have large MDT meetings. So that's with the 4 consultant geneticists that I work with, and the medical director of the practice, Dr. Sandberg, as well as the genomics associate that works here very closely alongside me, and our genetics admin assistant. So we have a very kind of strong tight team approach to this, and it really ensures that patients have the best care throughout the process. So in the genetics of the week meeting, that's really my opportunity to review pedigrees with the consultants, discuss urgent referrals, and also go through results we have. So for the preventive panel that we offer here at 90 Sloane Street, myself and the consultant at our weekly meeting, that's the first place that we review any results. And if anything is particularly complex or requires an MDT approach, or maybe the input of a specific consultant in our team, then we can take that to the genetics meeting. So it's really kind of the first assessment of the results to decide if there's anything additional that we need to do for the patient. For example, sometimes a patient might come in for an indication like a family history of breast cancer. But actually, when we review the history, we see that, there's aortic aneurysms in the family, or there's some other cardiac issues. And so, it's important we discuss that with a patient in their appointment as well, so that they know that there's an option there that they might wish to explore. So this really summarises the tests that we've spoken about over the last few weeks in the webinars. I know we've mainly focused on the preventive panel, which is on the far left. And Tessa today has spoken about the carrier panel that we offer here, the biggest being that one through Fulgent that looks at over 400 recessive and X-linked genes. And in addition to those tests, we offer a larger whole genome screening and also rapid testing for patients. So that might be people affected with cancers or other conditions that need results sooner that might influence treatments. And we have the test to facilitate that as well, to ensure that they get the result when they need it. So this really, the psychology of genetic testing is really where my skills lie, and what I was kind of trained to do, and that's really understand how different patients approach the process, and the different impacts it might have on them. So my role as a genetic counsellor is very supportive. And it might even involve phone calls before they get through to an appointment to navigate their fears and anxieties, and gain trust really in our service before they even come in for a test. In a consultation, I check in throughout, and that's to help me understand, are they a pragmatic patient that just wants to know everything, wants to act on it, and isn't particularly concerned about the outcomes, even uncertain outcomes or maybe unexpected outcomes of a large panel test. Or are they quite nervous and anxious? Is there an affected family member? Have they lost family members to a certain condition? What's their experience, and how might that impact how they perceive the genetic testing process? So It's very supportive, and I come in before the testing, during the consultation as well. As I said before, quite non-directive, empathetic with patients, and also allowing them time. Some people aren't ready to go forward with a large panel test the first time they hear about it. You know, they need to take themselves away, think about the information, you know, consider it, speak to family members, before deciding to go ahead. So all of those things, you know, where my skills come in and allow me to work with the patients, to be a support for them, and also direct them to other channels of support if you know, there's somewhere else that might be best placed to give them that support. You know, for example, there was a patient recently who was affected with a breast cancer, and you know, we discussed in clinic that, you know, potentially some additional psychiatric support might be useful for her before she had her results. And that's something that, you know, she pursued, and we spoke about again once I gave the patient her results. So, you know, it's kind of continuity of the process that they speak to me at the start, and then normally I'm the last person as well to check in and ensure that they're adjusting to their results in the right way. So in the preventive screen, really, we do have some people who might have the testing all on the same day, but I come in at 2 points within the process, and normally that's the initial genetic counselling Zoom appointment, where I give them all the information about the test, and we discuss things like mental health, family history, and that's sort of the big information session. And then if they decide they'd like to go ahead, and there's the opportunity to not proceed if they don't feel it's right for them, then they come in for the bloods and the consent appointment, and they normally see me for that as well. And then depending on results, will, you know, whether or not they see myself or they see one of our consultants. So that's where my role lies here, in kind of answering their questions. So in the preventive panel, the main groups of genes that we look at, as we've discussed before, are the cancer genes and the cardiac genes. And in relation to the cancer genes, this image here is something taken from our brochure, and it's something I use very often in consultations to give, you know, people who are visual learners a better opportunity to see where some cancer risks lie in relation to some of the genes that we look at in these tests. So a really important thing that I focus on is some of the types of cancers where there may be less actionable things that we can do. So in our preventive panel, all the genes are selected because the largest risks are actionable in some way. So, you know, our hope is that we can improve outcomes and outlook for these patients where we do find a harmful change. But sometimes, you know, for example, with pancreatic cancer, albeit these risks are smaller than these larger kind of breast and ovarian risks that you see on the left, for some people, and you know, this is where different risk perception comes in. For some people, you know, a 7% lifetime risk is significant, and that's something that might worry them. And we know that with pancreatic cancer screening currently, you know, there are methods that can be accessed in the private sector, as well as potential for, you know, research studies, clinical trials, depending on family history. But it may be that, you know, patients have financial limitations. That means they can't afford to access that private screening. Or it might be that they just don't want to live with that uncertainty or not being able to act on some risk. So this is where, you know, I come in and we have a discussion about how a patient might feel about an outcome like that, compared to the risks that they can action. And a lot of the time, you know, they kind of reason that the biggest risks are actionable, and therefore they feel that it'd be worth it for them. But in, you know, a small amount of cases, there are people who decide not to proceed because actually, you know, they're not ready yet to learn about risk that maybe isn't so actionable. So that's why that conversation is so important. In relation to the cardiac genes, same thing really in terms of, you know, what can we action and what can't we action. And we know with a lot of the cardiac genes, you know, there's a low penetrance. So it's evaluating, you know, where that screening might be needed. And that's where the family history, you know, comes quite strongly into that. And we need to review any results we get alongside the family history. With our preventive panel, we don't typically report variants of uncertain significance. But if I, you know, have any tests that we do report that, then that's something that we also need to go into in a genetic counselling consultation, because that has, you know, its own group of uncertainties associated with it. As well, again, financial limitations comes in here. So some screening might have to be lifelong. So, are the patients sort of willing to fund that themselves, or actually, could they access screening on the NHS? So for many of these genes, follow-up, if we find a harmful change, will be accessible on the NHS. It's important to discuss that with patients and let them know about that. But it's also important to let them know that for some of the genes, there might be limitations where they have to access private screening. So that's something that I would go into a little bit more in relation to the cardiac genes. And there's an important point here in the sense that when we do see affected relatives in a family history with a cardiac condition, if that affected relative hasn't had a genetic test, we don't know whether we'd be able to identify a harmful change in them or not. And in many cases, we can't identify a harmful change, even though we can clearly see a dominant inheritance pattern in the family. And so in that case, it's important for patients to be aware if we get a negative result, it doesn't necessarily remove their risk, because actually, we haven't had a test in the affected person. And so that's something I will explore with them in the family as well, and potential to communicate with that affected relative. So with regards to giving consent, at 90 Stone Street here, we do mainly see adults. So it's mainly adults that we do testing for. And in this case, it's adults generally who have the capacity to consent for their own testing. So, particularly, I think more so in the NHS, you see adults who might lack capacity that may be considered for genetic testing because it's in their best interests for their care. But here mainly, we deal with people that are electively coming forward because they want to have a health screen, or they're having testing to influence that might impact their own treatment. So they're the people that are normally giving consent here. This really is just showing the consent form that we use as part of the preventive panel. So as you can see, there's quite a lot of information. It's quite a lot of text. So for a patient to be left on their own with a form that's so large and quite overwhelming, we'd worry that they might miss the key points of the consent form. And after I normally see them for a counselling appointment, particularly if that's over Zoom, we send copies of this beforehand for patients to have a look at. I cover most of the material anyway in the session, and then when they come in for the blood sample, I highlight the key points, and it just really, I think, highlights the importance of having a trained health professional to go through these really quite extensive consent forms, particularly for large panels. It's not something you'd want to leave the patient alone with if they haven't had the right guidance from a health professional. So as with all genetic testing, there's always ethical, moral and legal considerations. And again, there are things that come up in the consultation. So variable expressivity and penetrance, and also, genes that, what can we actually do? Can we actually action them? So I think, again, Tessa mentioned in her cardiac genetic presentation about the decision of the team not to include the SCN5A gene in relation to cardiac testing. And we might revisit that in the future. And as she mentioned, that, some people might disagree with that, but it was really based on the idea that, is there anything actionable we can do? Or actually at the moment, is that quite limited? So there's no treatments at the drug treatments at the moment associated with SCN5A changes in relation to Brugada syndrome and long QT3. And so they're all things that, we constantly discuss and revisit, and a really important ethical consideration before we give that information to a patient that we can't take back. Also impact on insurance for patients. So with a predictive test at the moment in the UK, there's a moratorium in place with the Association for British Insurers that means that they can't ask for results of predictive tests in the UK. And that's only the only exception to that is for a condition called Huntington's disease, which we don't look at in our tests. So that's something I discuss with the patients, because for a predictive test, it's not relevant in the UK, but actually if it becomes diagnostic, or that patient already has a diagnosis, then it might be something that they could ask about in new policies. So it's important patients are aware of that and how it might impact them financially, particularly if then they need kind of screening afterwards or follow up for any gene change we find. So it's really important to really explore that with the patient. And there might be different requirements in different countries. So in America and Switzerland, the requirements are slightly different in relation to whether or not they'll ask for results of the predictive test. So for testing in children, we don't typically do that, because we know ideally you'd wait till the child is old enough to decide whether or not to go ahead with the test themselves. And here, we don't offer any of our panels, of course, to children. But it's important that, you know, sometimes we can find gene changes, although there's less of them, some of these gene changes are actually relevant in childhood. And so things to speak about with the patient when I have my counselling session with them is, you know, how they might feel about risks potentially being relevant to children, and also the potential for screening of children if we do pick up any gene changes. So for the few, you know, cardiac gene changes and some cancer such as TP53 and Li-Fraumeni syndrome, where there is relevance to children, that's something really important to explore with patients in counselling, because you know, that might be a very unexpected result. And normally we see strong family histories with those kind of gene changes. But there's, you know, there might potentially be an indication to maybe test a child in the NHS, for example, if we found something in a panel test, albeit it is very rare. And also different religious and cultural beliefs, so just ensuring to be very non-biased in approaches and giving people all the information to make their own decisions and choices. And just that understanding as a healthcare professional that, you know, just because a decision might seem unwise doesn't mean it's you know, the wrong decision for them. If as long as they're informed, making an informed decision, then they have the capacity to decide what they act on and what they don't. This is just a case study more in relation to the carrier panel that Tessa spoke about earlier, just to think about some of the considerations and limitations of some of the testing that we offer. And it's very similar to the example Tessa gave earlier about the limitations of what we can and can't find in our carrier assessed panels. So recently I saw a couple who were seeking IVF treatment abroad, who were of advanced maternal and paternal age. And they wanted to have the carrier panel test to see if there were any increased risks of recessive or X-linked conditions in any potential future children for them. So as always, and as Tessa said, that, you know, there's always that risk of new dominant conditions, not being able to test for or not knowing about certain changes in genes, or not including certain genes in our carrier panel. And with this couple, there was kind of an extra layer in the sense that there was quite a large potential that they were going to have to use donor eggs, just due to the advanced maternal age. And so that was something as well I needed to explore with them in the appointment. And so in that discussion, you know, the limitations of the test was really important. So that de novo risk, particularly in males of advanced maternal age, in the sperm of new dominant conditions, and then understanding really what the restrictions are. You know, we cannot detect that with our carrier panel. And that chromosomal risk, particularly again in women of advanced maternal age in the eggs and embryos. So just ensuring that they're informed about those risks before they go forward. And managing their expectations. So, you know, being separate from the IVF clinic, just making sure that the couple understood maybe the likelihood of the use of donor gametes and how they might feel about that. And the relevance of the test, you know, if it is likely that donor gametes will be used, then maybe the result might not be that useful for them moving forward. So just ensuring that they knew what the likely relevance of the results would be for them before they decided to consent and go ahead with this test. So hopefully that kind of gives an example of a case where, you know, there's kind of lots of different layers and things that you need to explore and make sure people are informed about. So frequent questions and discussion points that might come up in any given consultation. So in family history, it's really important to look at ancestry, because we know that certain gene changes are more prevalent there, like in the Ashkenazi Jewish community, and also to be aware of things like consanguinity when I take a family history, if there's any recurrent miscarriages that might indicate a certain condition, particularly recessive conditions, and also to explore networks within a family. Uncertainties, as I said, we don't typically report uncertain changes in our preventive panel and whole genome screening, but other test providers we use might report VUSs. So it's really important to explore that with a patient, and so they know whether or not they'd like to receive that type of result. Also DNA and data storage, so some just, you know, complexities that we go over in the consent forms about how long the lab might store their DNA and store their data. And insurance. So, you know, will testing be covered by the private health insurance is a question that we get a lot. And that tends to only be for affected patients, but it's something, you know, we can discuss with patients. And will their life and health insurance be impacted? And we know at the moment, if it's predictive, it won't in the UK, but it's just something that, you know, it's important that we understand that a patient's individual needs and kind of where they live and where their insurance is, to know what the implications is for them. So hopefully that gives kind of an overview of my role, some of the questions I get from patients, and you know, some of the support and help I give to patients to navigate them through the testing processes. So this is just a slideshow to show our team, and I think you've heard from all of us now in the series of webinars. So I think most of us are in this final webinar here today, and happy to answer any questions about the process or anything you've heard today. So yeah, so thank you very much for listening, and I'm happy to take any questions.